Hello, everybody. It's wonderful to imagine that we're going to be sitting here talking about the opportunities of using one of the most exciting aspects of instrumentation within the chiropractic realm these days, and that would be heart rate variability, pulse wave profiling. We're going to be talking about, and we're going to focus really on the aspects of what make chiropractic such an important aspect of today's world, as it has always been, but especially when we start to use the tools that were infinitely designed for us. So welcome to the Insight Deep Dive, and this is part one of three. We're going to be building a neural profile for you so that you can represent yourself and chiropractic so well within your community. I want to remind you that there are chat functions associated with this webinar, and you're more than welcome to leave them. We are standing by. We don't always get a chance to answer. There's so many people that have signed up and registered for this program. We may not always be able to answer on that moment, but we certainly will make an effort to try and get back the answers. I'm sure there will be some of the similar ones. So we're going to get right into it. We have the opportunity, as I said today, to do a deep dive. And what do we mean by a deep dive? Well, it's not a shallow dive. A shallow dive would be something that would be very, informative, that you might want to give to a patient or some information. But we're talking to doctors and to clinical staff here, and so the relationship we have is to allow ourselves this opportunity to really dissect and look at why heart rate variability is so critical in the application of chiropractic in today's world. So one of the things that I love to do is sort of get you into this idea of where we're going to be taking the day. And I think it's really important that we have this sort of background as to where we're going to go. So selectively, I have chosen keywords to really keep ourselves focused on the importance of using a technology like the NeuroPulse, so that we can talk through the responsible approach of what chiropractic is all about. So we're going to be talking about salutogenesis, and I'll go into what that represents. Adaptability, which I think is probably the key word in today's very, very busy world. We're going to introduce the concept of adaptive reserve, and I'm going to introduce how we can use an index, which is known as the Autonomic Activity Index, or AAI. We're going to talk about autonomic balance, and again, use an index of the ABI, which is the Autonomic Balance Index. I'm going to introduce a term that is very prevalent within CLA, which is known as the neurostorm, which really speaks to a sympathetic dominant state. We're going to reference a vagal tone. We're going to introduce a concept of resiliency, as we name it, through bounce back. And that's going to tie very nicely into the AAI reserve. Obviously, we're going to be dancing around the concepts of neuroplasticity. And finally, we're going to be really focusing on what is so chiropractic, which is this concept of coherence, or what we have always put in, and what Stevenson was very clear with in the 33 principles, was the notion of ease. So we've got an exciting time with you today to really focus. And just so you know, because we're talking HRV talks to every one of these key words. So that's what's so exciting about having this opportunity to move this forward. So I introduced the concept, or the word, of salutogenesis. And I think it's really a great starting point for us to really frame why and how we're going to be building on the concept of chiropractic HRV and the principles that drive us. So Antonovsky was a social scientist, and one of the things that really was important, not only to him, but in the evolution of the entire chiropractic model, was the distinction between pathogenesis, or the presentation of a disease model, to one that was associated with human potential, or the expression of health. And this ties so clearly, when we talk about salutogenesis, into where we're going to talk about the functioning central nervous system. And most importantly, what we're really going to be talking about is your impact, our impact as chiropractors, to not be trapped in a pathogenic model, but more importantly, to be focused on outcomes that are associated with salutogenesis, which stands for the origin of health. Now, health is really a component. It's not the end goal. Health is part of a very complex, flexible relationship with our nervous system, which associates with physiological, psychological, cognitive, and emotional relationships. And so as a result of that, we now, when we build a salutogenic model, really start to recognize that we aren't confined to looking at an end organ that isn't functioning well, or looking at lab results that simply are associated with the body trying to work its way through a pathology. What we are doing is recognizing that our role as chiropractors is to arouse innate, as the principles teach us, but to look and measure the process of whether we are approaching a more coherent salutogenic state, or are we trapped in an out of ease, noisy, incoherent state in our nervous system. Antonovsky went so far as to talk about a state of coherence, or SOC, because he recognized that one couldn't achieve salutogenesis unless there was coherence in these complex systems. And it was recognized that if you jumped into a salutogenic model, you distance yourself from pathologies, but what you never did was you never gave up the idea that pathology was an honest and real endpoint of where systems that came out of coherence could only go. It's the principle of entropy. So I want to focus, and it's right here on this slide, is that the origin of health, or salutogenesis, is a stress resource-oriented concept. And it focuses on resources. And that becomes critically important because the most valuable resource that any human being has is their autonomic reserve. And that means that they are using their central nervous system to give them not only their ability to interpret themselves in their environment, but to react appropriately without expending so much of those resources that they become more vulnerable. So this is where it gets really exciting, because this is our domain. And so when we take a look into what HRV is going to give us, it's going to be looking into the tone or functioning capacities of the autonomic nervous system. And we have to remember, which is why we're going to be talking about deep dives going beyond HRV, that the autonomic nervous system is one branch or one division of the central nervous system. Now, the motor nervous system is what we're going to be talking in a deep dive about EMG, and another division, which is the regional sympathetic motor division, or spinal autonomics, are going to be measured by the thermographic deep dive. But today, what we're going to be talking about is really this global interaction of the autonomic functions that keep us not only regulated, but, as you're going to find out, that they keep us in a state, what coherence means, which means that we're at the top of our game, which means that we are so well adjusted that we can not only see ourselves in an environment, but we can see ourselves beyond that and become creative entities. Really, by the time you understand the impact that the autonomic control and mechanisms have on being the best chiropractor and being the best chiropractic patient that you can be, you're going to see that HRV is an indispensable aspect, and that the neuropulse itself was designed specifically to associate with outcomes that are affiliated with a chiropractic model. That's how we set up the graphing. So this is a neuropulse. For many of you on this session today, or who will be watching, this is familiar territory. If you'll notice behind me, there's one that's actually live. And one of the things that we know is that this instrument is actually referred to as an autonomic station. It performs what is known as pulse wave profiling. And we'll go into that in just a moment, but it is designed to capture through your fingertips a series of autonomic functions. One, and most importantly, is the interbeat intervals of your heart rate. And we'll talk a lot about that as we discuss the data. But while we are measuring using the neuropulse, the capacities of us to measure down to the third decimal point of your heart rate, then what we are also doing is live streaming the temperature of your hand, if you will, of your ability to regulate temperature, but also, and probably more importantly, is your state of arousal. In other words, those gold-plated sensors that you can see are affiliated with capturing what's known as a pseudomotor activity, which is galvanic skin response or skin conductance response. And this is like a lie detector test. And what it's doing is that it is live streaming us to understand your state of arousal. And when we are interested in doing subluxation centered assessment towards what we're going to do in test and retest and retest and test again, is that we want to get a consistency to assure that we are capturing all of the heart rate so that we can calculate heart rate variability in a consistent manner. And this is what really separates us from the wearables. I'm wearing an iWatch, from wearables that could be affiliated with a different approach to HRV, which is to look at recovery models after exercise, or themes of the ability to watch and see how your heart rate is at interval times, like, for instance, awakening. What we're interested in primarily in a chiropractic setting is understanding if we are moving you towards a state of greater coherence under a chiropractic model, and whether when you leave the office, a patient is maintaining their ability to keep this rhythmic approach, these trends, as we're going to be talking about, of moving towards a very well-adjusted, coherent state. So, to do that, we have to be able to use the finest level of technologies. And so one of the things that we need to do is understand why and how the heart is associated with looking at the autonomics. And so this is why we are going to talk about heart rhythms. Now, the heart, of course, is a prime oscillator within our system, and it actually has its own intrinsic brain, if you would. It has its own intrinsic neural network. And this neural network is intimately connected through the sympathetic and parasympathetic responses directly to the brain. And not only is the heart associated with pumping blood and functioning towards keeping that system going, it is acting as an information driver, both afferently and efferently, towards what is occurring both in the emotional state, the psychological state, the cognitive states. And you're going to see, as we start to take a look at studies that have been affiliated with HRV, the complexities of this system are so important to understand. Yet, and I just want to put a little model of knowledge in here, is that the purpose of today is not to give you a complete lesson on what HRV is, enough so that you understand it, but there are so many more ways in which you can become more masterful at learning HRV by just digging in and taking other courses associated with heart pacing, associated with functional neurology. And I just want to put a star beside why today's session is so important, because we're going to distill, if you will, the importance of understanding whether we are looking at patients and seeing if they are moving towards a state of being well-adjusted and coherent, or whether we need to do other strategies to combine our associative care planning and otherwise. So I want you to see what I've written here primarily, and this is so important, is that complex systems, and goodness gracious, neural networks, but importantly, human beings are complex systems, and they are most adaptable when they are flexible and not rigid, meaning that they have the ability to adapt. And so if we take a string, let me play this game with you, because there are certain levels of sensors that we need to understand. If I ask you to take your two fingers, and you might want to do this right now as we're talking on a webinar, and have them place them on your carotid and feel your pulse waves. Now, when I go to do that, let's do some simple math. If you have, using these two sensors, if you have a check that says, I get 60 beats per 60 seconds, then that means that the autonomic balance that's associated with that and the interbeat interval is 1 per second, or 1.000 seconds per interbeat interval. Well, guess what? That's about the level of validity and reliability that these digital sensors have, but we can do better than that. We could hook you up to an ECG, but that's very, very awkward and is designed more for the pathology-based model. In a salutogenic model, we use a technology called photoplethysmography. And photoplethysmography is a way in which we check the pulse wave pattern. Now, in this particular image that I'm showing you, which is an ECG, we're looking at the ability to collect what are called RR intervals. Well, we can do exactly the same in a PPG test, and the reliability between ECG and PPG is profoundly close. So that when we do a hand test like we do with the Neuropulse, it actually is giving us remarkably accurate data of these interbeat intervals. So much so that we can collect down to the third decimal point as well. And you'll notice that there are variable beats per minute in a normal string. This is only 2.5 seconds of heartbeat data, and you can see it goes from 70 to 76 to 83 BPM. And why is that? Well, there are many different mechanisms that affiliate with how a system is constantly interpreting itself in its environment, but it is playing around with it. Baroreceptors are looking at beat patterns. There's vagal tone that's associated with it. We have visual inputs that are visual cues that are coming to what is known as the posterior vagal division. We're in this myriad of neurology, looking at temperature, managing arousal states that are going on for all of these things. And all of this is baked in to this variability. And this flexible system means that on a moment's notice, and I mean a moment's notice, whether it's in a hair on fire emergency or whether it's a slow responsive need to build up your sense of activity, we can go from a state of being very calm and peaceful to where we're needing to draw upon our resources to fight flight, which would be a sympathetic dominant state, or go into a rest and recover and digest state, which is more parasympathetically dominant. So an innate variability in the timing of the ABI ensures that the ANS is in an adaptive state. So if we have very low or rigid variability, if all of those were locked in at 60 BPMs, it would be low variability. So just keep that in mind as we start to unravel a little bit of the data that's associated. So the calculation of HRV uses two different ways in which we can look at that string of heartbeats. Now, typically in what was known as the 1996 heart pacing indices, it became very clear that you needed enough of these interbeat intervals to look at the time and frequency variables that were associated with it. And so in the early days of heart pacing, there was a recommended 5-minute pacing that was affiliated. Now, when you're looking at pathology-based cardiology models and otherwise, many times they can do a 24-hour Holter monitor and check HRV over all of those data streams. But for the need to look in a salutogenic model, a 3-minute collection allows us to have enough IBIs that we can understand changeability and develop an understanding of the state of coherence. So there's a lot of data that we're analyzing, but to keep it really simple, we're analyzing through the data of these interbeat intervals, this ability of the nervous system to find a rhythmic balance. Well, let's go back to neuroanatomy for just one moment and remember that for a heart to beat, it has to have autonomic sympathetic input to get the body rolling. And let me give you a little bit of this. It's not like it's on and off. If we were to take all the neural inputs away from a beating heart and we put that beating heart in a lab environment without any neural connections, intrinsically that neural network of the heart would keep the beat pattern, the beats per minute, at 100 beats per minute, give or take a few here or there. But the average is 100 beats per minute. Well, that should tell you that there is a consistently high level of heart rate. So if we look at anything that is lower than 100, that means that the parasympathetic or vagal tone to that heart is actually in play. And so the higher, this is one where you have to think this through, the higher the heart rate, the less the variability because there isn't enough parasympathetic modulation. And this is for adults. And so one of the things that we need to help you understand is that there is this constant interplay in the timing of the heartbeats and a look and see to see if the vagal brake, or the ability of the vagus nerve to brake downwards from 100, is working well. It's very cool stuff. Well, interestingly, when a nerve is firing, there are also tremendous differences in the frequencies. Now, it's generally understood that parasympathetic frequencies of that firing fall within a range which is called high frequency. And low frequencies are generally, and I put sort of air quotes on those, described as part of the sympathetic responsiveness. Lots of discussion on that one. But the interplay, or what matters in calculating the state of coherence and this modeling, which is affiliated with a, we'll call it wellness model, is the LF-HF ratios. And this is one of the things that when you understand this data table, or we take a little bit deeper look at it, we can look at those ratios. We can dissect and put them through a lot of complex mathematical models called fast Fourier transforms. And we can start to really understand those variable mathematic models, so that a fractal of time, which is associated with the time frequency, can be time domain, can be then understood in terms of which frequencies are developing those shortened time frames or those longer time frames. I hope I haven't lost you on that, a little bit of geeky stuff. And there are so many different pathways that are affiliated, but to keep it really simple, the sympathetic control mechanisms that go to the sinoatrial node in the pacemaker, if you will, in the right atrium, the sympathetic motors that come to that are directly from the upper thoracic spine of T1 to T4, and the parasympathetic motor responses that affiliate with the ability to control at the sinoatrial node the beat pattern are coming directly from the vagus or cranial nerve number 10. It is the cranial nerve number 10, or vagal tone, which sets HRV in play, which helps us measure it. And it is the vagal tone that is going to distinguish how much reserve we have. And so to keep it simple, as we go down to understand this, there's this necessity to understand that if a person is stuck in a neurostorm, in a sympathetic dominant response, it's very catabolic to all of their body systems. The body is expending massive amounts of energy to keep their quote unquote foot on the gas pedal. But a braking system, hopefully not emergency braking all the time, but a constant braking system, is very much to the positive, and that's the value and what allows us to keep our energetic responsiveness, or autonomic activity index, rising. I hope you're getting a feel for how the joy of managing this is there. Now, this is a bit of a complex slide, and I put it in more so that when you go to review this in the future, and I'm not going to go through this all right now, you're going to have a reference point to this. What you need to understand is that if we go down to under time domain and we see standard deviation of IBI is also known as SDNN, that is the logarithmic equivalent of calculating the heart rate variability in what we're most interested in. It is the most stable, calculable outcome that we can use time domains to function with. And that's called SDNN. And that is in comparison. You can still do another. There's 3 or 4 different ways in which you can calculate HRV, but the root mean squared standard deviation of IBI, or RMSSD, is another one you'll come across in the literature. Nothing wrong with it, but SDNN tends to be much more appropriate as far as a measure, especially in short measurable models. And just for your information, that don't have VLF or very low frequencies. We don't collect enough data in 3 to 5 minutes to even take into considering the VLF frequency. When we go down to the frequency domains, we can see the VLF that I've mentioned there, but we mostly focus on LF, which is more towards the sympathetic side, and HF, which is affiliated with the parasympathetic side. Normalized just means that we take those data sets and we make them into percentile units, and that then allows us to look at these different ratios. So hopefully we've gotten past the necessity to take a look at that, but this is what I want you to take away from it. is that a neurostorm or a persistent sympathetic dominant state raises the heart rate, right? You give somebody more adrenaline or norepinephrine and their heart rate is going to go higher. And that means that there is less of a spacing, if you will, between the heartbeats in a given amount of time. And that means that they have a lower heart rate variability. Whereas the opposite is true, is that if we activate the vagal activity, it decreases the heart rate, which increases the HRV. So an increased HRV is synonymous with a very active vagal tone. And that's phenomenal because it's in the high vagal tone that we get some of the greatest healing responses, but also we can extrapolate beyond that and we can start talking about the humanness of the person, which means that high vagal tone is directly related to cognitive and emotional stability and activity. So very exciting to know that here. And oh, by the way, guess what chiropractic is notoriously fabulous for, and we're going to look at that in this research studies, is increasing vagal activity, normalizing this HFLF balance, and building up more and more reserve within the patient. And that's where we have our beautiful data sets. So here's the other thing I want you to know, is that sadly, but we know this from aging, is that people who age tend to have lower HRVs. Well, that's not something that's terrible to know, but it's super exciting to know that patients that are under chiropractic care actually have this senescence occurring because they have much less aging as they go into the cycle of a more functional autonomic nervous system. This data set is in general population. And when you start to investigate where your patients on their age cycles are very much associated, you are going to be amazed to know that they fall to the left on the horizontal axis, is that we start to see a left shift with people's aging processes, and they experience a much higher long-standing HRV. So that's very exciting. So what do we do? Well, with our particular interesting technology. And by the way, we're exceedingly proud of our technology, and so are many others. Obviously, we have become the gold standard when it comes to chiropractors in their clinical practice using HRV. We are the most utilized chiropractic technology for HRV. And as a result of that, we need you to understand that the value of what the graphs we're going to be showing you were designed specifically for use through a comparative model of what we know a well-adjusted nervous system looks like. So as a chiropractor, you can not only understand HRV or the improvements like I just showed you on a data set that looks like this, but then we take the next step at CLA and take the data that you're having in the HRV world and compare it to where a well-adjusted person should lie. Well, what you're looking at is the data set of somebody's what's called instantaneous heart rate, which is the red line. And you'll notice that this is a 3-minute collection. And so you can see that this person has a lot of very controllable heart rate in and around the 50 to 60 range. And obviously that is going to tell us that they have good HRV, or good vagal tone, I should say. We don't know about their HRV yet, but they have an active vagal nerve because they're obviously functioning at less than 100. We also have in here a blue line. And that blue line is running, as you can see, simultaneously. And you can see that there's a range that's acceptable. And this is the range of arousal. So at the same time as we're collecting this data stream of the heart rate, we are understanding whether that person is in a calm state. Now, if we wanted to try and alter the data, we could have them do paced breathing, or we could generate a false calm or resting state. But what we want you to do is recognize that if we can have that person sit in a very stable state and we can observe that they are not in an aroused state of, I don't know, watching their iPhones or watching a movie or a door slamming in their environment, we would pick up all of that instantaneously, and it would plot where these blue lines would go above the threshold. And we have made sort of a general state that if we get 3 relatively large breaches, 1 per minute, if you would, that we would consider that that would be collecting in a state of higher arousal. And we would ask you to redo the test in a lower state of arousal. Why is that important? Because when we go to compare apples to apples, going down from initial to progress to comparative to continuation, we want you to know that you are reporting on exactly the similar collection model. So this is one of the things that allows us to be, and I don't want to say the darling, but I will, the darling of the chiropractic research community. We have become really the most sought after way in which we can deliver consistent results. And on top of that, and I'm very proud of this, we have by far the largest data sets, the largest data tranches of any clinical profiling that's been done within chiropractic, not only with HRV, but with EMG and with thermography. And we collect all of the data sets. So we absolutely are collecting millions of scans and many multiple millions of data points, literally in a month-by-month basis through our network. And it is this data that is driving research right now into understanding the importance and the power under which chiropractic makes a difference, not only for how a person feels, but directly how they function. And it's with these type of data pools that we know that the future of chiropractic will not be tracked in a limited musculoskeletal model, but Canadian in me, is that what we absolutely know is that the profound nature of just what I talked about earlier, salutogenesis, is very simply this, is that if subluxations detach us from our wholeness, then adjustments reaffirm the connectivity, and it isn't limited to a structural or even local phenomenon, but that we adjust people. And as I have said before, is that when we subluxate with every cell of our body. And what I'll tell you is that when we are adjusted in a coherent state that goes far beyond the simple biology of cells into the continual activity of potentiating human creativity and the ability for us to function at a completely different level. And for those of you who know this, HRV is the ideal tool, and it breaks it down into the simplicity of a simple way in which you measure it and a simple graph like you're seeing here. I think one of the most exciting things that we did with CLA was to take very complex, and I'll flip backwards, very complex data sets, which any HRV system can gather, but we put it into an incredibly usable, trackable state. And we made it so simple that we gave you not only targets, but we then gave you a simplicity of an XY axis, if you would, to where you're looking at autonomic balance and where you're looking at the ability for autonomic activity to rise. So let me teach you a little bit about what this graph, we refer to it as the rainbow graph for obvious reasons, but it's really what I call an adaptive graph. The green zone is really important for you to understand. In checking HRV in general populations, much like on the data sets that I was showing you before, it's very much assumed that there is sort of a normative range under which certain age groups should fall. And what we did was that we took a general range of adults across the spectrum of generally the young to the very old, and we looked and saw where a scatter plot would put it. In fact, we did 2,468 HRV scan data sets on well-adjusted people, and the scatter plot brought us to this zone that you see in the green zone. So this is a desirable plot for where we know we want your patients to live, reside, or get to. And this means that they're operating in a well-constructed autonomic balance. You'll notice that the green zone is bracketed by a square box. And that zone allows us to have a latitude, as we discovered in the data, of being slightly sympathetic dominant, slightly parasympathetic dominant. But most importantly, you'll notice that the activity levels fall at the 80 and above zone on our indices of autonomic activity. Now, what I want you to understand is that the normative threshold of where we saw all of the data plots of where the average entry was was that horizontal line that sits somewhere around the 70-71 zone. So that is where an average person would come in, and a well-adjusted person could be well above 100. But the low threshold that you want to try and achieve should be at minimally in the autonomic activity zone as you go forward with them. You would want that to be at 80 and above. So if you take a look at the bottom of the graph and you go into the labeling that's on there, you'll notice that we've split the graph into a center line which keeps sympathetic on the left-hand side and parasympathetic tone on the right-hand side. And that's related very clearly to the frequencies that we know we're capturing. And that the autonomic activity index, which are based on algorithms that we created looking at this data, is associated in this case with 69.26, much below the 80. So we would know almost immediately that this person was sympathetic dominant. In fact, they were only operating at a 57.24% balance in their autonomic functionality, and that they had depleted their ability to keep that reserve, if you would, up above that line and certainly into the green box. We would then take this into quadrants, and we now have, based some languaging, but also some neurophysiological clinical aspects to what each zone represents. And I'm going to go through that now. And one of the things we know is that the vast majority of people we meet when they enter into a chiropractic world have sympathetic dominant as their resting state, and that they have depleted their reserves so that they tend to plot primarily in zone 3, which is really disturbing because zone 3 represents a distress state. And you know what? We probably need to recognize that stress in itself is not the problem. It's living in a distress state, which means that stress has become the baked-in neurological set point, the maladaptive new normal. And how many of us live there ourselves? Lower than the threshold, lower than the 80 desirable zone on the autonomic activity, and tilted to the left. This is where the person's autonomic responsiveness is blunted, and as a result of that, they need to re-engage the vagal tone so that it draws them back not only in towards the center line, but because they're no longer depleting their relationship with their autonomic activity, that it naturally elevates them above the threshold and gets them into perhaps zone 1, zone 2, but especially towards zone 5 or the green zone. And as we'll show you in case studies, that's very reasonable. If we were to look at what zone 1 means, it means it's uptight. We also have sort of an in-house conversation about what zone 1 means, and we refer to that as the as the over-exercised group. And these are people that have a lot of reserve as they go into the testing protocol. They've done a lot of very, very positive things to increase their autonomic activity to where they have a lot of active reserve to work or draw upon. But here's the problem. They have very poor vagal tone because they constantly are overtraining. And because they're constantly overtraining, they are not allowing that rest and digest, that rest and recovery state of the vagal nerve, if you will, the vagal tone to kick in. And as a consequence of that, they stay locked high in the reserve. But we also see that they have a poor recovery pace. And one of the most important things for athletes or for us to look at people that have taken on a very dynamic ability for fitness or otherwise is they tend to plot up here and they try and overtrain without giving themselves the time or the appropriate approach. The good news is that if they adopt an adjustive model, that the adjustments re-engage vagal braking, and as a consequence of that, they can keep in their performance modeling if they modify a little bit of the recovery state. But what they really need to do is recognize that it is under their control so that they don't overdo their training and they stay in there, because I'll tell you the consequence is that if they stay in zone 1 for too long, they'll end up in zone 2, zone 3. Well, a little bit in zone 2 as they're drifting down. And we'll talk about zone 2. Zone 2 is an exhausted state. And typically what it means is you might think it's like, well, I think that we're a little parasympathetic dominant, and that's good. What you're really seeing in zone 2 is that they are sympathetic insufficient. And you're thinking, wait a minute, how can you be sympathetic insufficient when you are, wanting to always re-engage this? Well, it comes from not necessarily the vagal tone, but more hypoadrenia, which means that these people many times in a functional medical model tend to be associated with a hypoadrenic dysfunction, which means that when stress occurs, they don't have the oomph within their functioning nervous system to pick up and even get a good enough fight and flight response. You can just imagine how dangerous this is. And they go from exhausted into zone 4, which is where they have a weakened approach. And so if we were to apply a car analogy with it, zone 1, just remember these people are sitting at a stop sign, because we're testing this in the resting zone. Zone 1 is that they're sitting there revving their engines all the time with a full tank of gas. But we know that if they keep revving their engines, it's going to put a strain on the engine and they're going to drop down into zone 3. Whereas if we have the person in zone 2, it means that they're trying to drive, but they've got their brakes on. They're riding their brakes. They're constantly pulling themselves into a poor zone. And we know that over time, if you ride the brakes too long, those brakes actually seize. And that's what we see in zone 4. It's a very depleted or weakened state. And I'm really sad to tell you this, that if we see the majority of people in zone 3, which is the starting point, that we see very few people comparatively in zone 4. And the sad part of that is that by the time you live or are in zone 4, it represents a weakened state that typically takes them into a medical-based model. And not that that's wrong, but it means that they missed the opportunity as they were under observation to make sure that they were well adjusted. And we know the consequence of that is that we only barely see 7 to 10% of the population. That means that 90% of the population are somewhere out of the well-adjusted zone. This is realistic. This is not unrealistic at all, as we're going to show you in here. But we can take somebody, which I just showed you in that same plot point, and under adjustive care is very realistic. We'll go through case studies, but this is generally within a 12-week window of care. You can start to see changeability. This is a particularly nice plot that we see happening, but it is not unreasonable. Why? Because a well-adjusted nervous system brings back the autonomic balance and fully charges the nervous system. That's why we do what we do. And so one of the things that we need to do is understand how this is relatable within it. And so I thought over the next section, we could just confirm a lot of the relationships of the research that's being done. Chiropractic embraced HRV in the early days, but it wasn't really well recognized. And so one of the great researchers that CLA developed a lot of its strategies with was Ralph Boone. And Ralph Boone really took a look at associating the adjustments in the cervical and thoracic spine and looking and seeing what the sympathetic and parasympathetic responses were to it. And just to be clear with it, this goes back to 2007, 2008. It was in around that era of 06, and which is when the Zhang study, which is on the same page, started to come about. Was this interest was associated with the fact that if you were to apply an HVLA or a specific chiropractic adjustment, some of them were thoracic manipulations and other forms of it were the adjustments, as Boone was talking about, then what we understand was that when you brought the spine and a spinal chiropractic adjustment into play, you directly affected the control mechanisms of the sympathetic and parasympathetic responses, which means that that could be identified in the heart rate variability calculations. So there was no doubt that where there was smoke, there was fire, that there was this incredible opportunity to start using it. And look, heart rate variability in the research has been around, well, they started looking at beat-to-beat relationships and the modulation back in the 1700s, not with these were the digital ones, but by the time we started to get computerized digital processing of those signals, we could start to take meaning the health community, could start to take a look at specific use cases, whether it was in cardiology or in fetal alcohol. As early as 1965, they started to look at these interruptive neurodysfunctional states. We in chiropractic would refer to them as the subluxations that we were searching for. And that's what the start of this Zhang and this ability to look at what Ralph Boone's work. Budgell, who was from my alma mater, was in CMCC, was starting to look again at thoracic involvements too. And what if you were to take a look at what Boone was talking about, he was going to actually look and see the direct relationship of a specific adjustment and see if it activated more of the sympathetic and parasympathetic side. And there's still a lot to be learned about that, because it isn't a teeter-totter of where you're turning it on and turning it off. There are all of these complexities that are affiliated with all the different, limbic systems that are affiliated, the amygdala, and looking at prefrontal cortex. There's a lot of emotional tone that's affiliated with it. But what we know is that if we keep our focus not on a specific adjustment that's changing a specific organ system or a specific outcome, but if we take a look at that general salutogenic state of coherence, we win every time. Probably one of my favorite studies, because they used the insight on this, but more importantly, that were two of my favorite people within the profession, was Amy Haas and David Russell. And especially David Russell and I, we did a tremendous amount of work together to help us understand not only the relationship of instrumentation within there, but we spent a lot of time together working on papers that were affiliated with HRV. And I had the great honor of working with Amy Haas as she was preparing this paper as well, because one of the things that we know was that they took a very interesting approach, which was this sustained improvement. It's one thing to see, as the Zhang study did, that there was an impact, whether it be on a one-visit adjustment or over a period of 4 visits, or even somebody who had an applied adjustive care model and they searched their state of coherence, if you would, a year later. What we wanted to do was see if there was progression. And this is where we started to see this small but very profoundly important study that was published in the Journal of Chiropractic in Australia. And this is where we started to see, and you'll notice the different here we are, the different, you've already seen this. This was part of the study, was they presented these graphs. And in 6 different patients, they recognized that on every patient that was under active, progressive chiropractic care, that there was an elevation and an escalation in their ability to sustain higher SDNN, which was associated with greater heart rate variability. This is so powerful to know. And I urge you, even though I'm just putting these in front of you as abstracts, I urge you to engage your ability to search this out and enjoy the ability to know that you as chiropractors change lives, not just spines. And it's understanding HRV that you get a chance to do all of that. Another great friend of mine, and we presented this, he presented this paper at the same time I was presenting at the Sherman IRAPS conference in 2019. This was Dr. Otto Jenke, and he took it upon himself to do a case study that was associated directly with a woman recovering from breast cancer, and it was stage 4 breast cancer. And it was remarkable from a symptom-based and from a physiological-based level that this woman had gone through quite a distinctive improvement. But what was even more remarkable was that under the guidance of Dr. Jenke and under the ability of he and Dr. David Russell to coordinate the data sets, that this proved that there was a direct relationship to tracking improvements in a very complex case that was affiliated with, what would be virtually almost terminal cancer, that was associated not only with her general state of recovery, but that it was also trackable under a chiropractic model using HRV. And I didn't go into much of this, but it was the vagal function that was associated primarily with her ability to recapture her healing capacities. which is wonderful because as you go down this path of understanding the impact of chiropractic and HRV, you get to meet some really tremendous people. And Dr. Yuri Gidron is a researcher, and I met him originally in the European side of things, and he had begun doing a extensive understanding and search of, again, cancer-related research and HRV. And what came about from his studies outside of chiropractic at this moment, but what was more important was that same stage 4 characterization that I described in the Otto Jenke paper is a pathology-based model, meaning that there's this idea that cancer can be classified as going through these physiologic measurable states of stage 1 through stage 4. And what Gidron and decided was, well, wait a minute. What if we were to not look at the tissue cultures as what stage they were in, but more importantly, let's take a look at the human and their state of coherence as we did. And let's look at those same people and understand if perhaps HRV is a more useful tool than looking at the pathology, but to look at it in a salutogenic way to understand that there is progression or at least identification as to whether that person is locked in, as we see here, a stage 4 medical-based, crisis state, or can they be classified or given more hope, if you would, that they can start to move themselves not through classified 4, 3, 2, 1, but more importantly towards a greater state of coherence. And so it was so important to understand that, because his statement was, if you have an active vagus nerve, the cancer stage may no longer be important. And here's an interesting one that I put in, is that we start with, on the left-hand side, a zone 4 plot point that we see, and it's really desperately difficult when you get these patients to see improvement, especially in their autonomic activity. But this is indeed a patient that has moved from that stage 4, fourth zone classification more to the central line. And this is why you want to give HRV its due when you are starting to look at care planning, because somebody who is in zone 4 like this needs greater attention, not just because they're lower than that low threshold that we see here, but because they are in that exhausted state. You need to have time to not only adjust them, but to allow neuroplasticity and the re-engagement of brain to heart health, the re-engagement of the sympathetic balance, the re-engagement of the rest and recovery state to kick in and do the magic that we know that chiropractic is. These are lifelong necessities to be under care of a chiropractor, because we need to observe, not just HRV, as we're going to talk about in future ones, but to look at the entire spectrum of what their structural tone, the motor nervous system, is doing, and what the regional autonomics are doing. That's why this is the starting point of where you can gain control, not only of how the patient feels, not only what their thought lines are, but to understand that you can build care planning with confidence around where we are going with this. So what do you say we look at some interpretations? And I've sort of put together 2 case studies, if you would, in progressions. These are absolutely terrific. One is an adult case study, and we're going to talk about a child case study as we go down this. So I put these down into what I see, and of course, in the communication, what I say. And so this is, you might be interested, this is graphic representation from our latest software, which is known as Synapse. And the Synapse system is a very fascinating approach, one that's so exciting because it operates. You'll see that these are coming off of an iPad image, but it allows us to build remarkable reporting as well. And so you'll see a little bit different reports. They capture the same data, but at the same time, you're giving yourself and the patients the opportunity to learn. I want to introduce at this time, for those of you not that familiar, this is about HRV, and we'll build a construct on the further deep dives. But you'll notice on the right-hand side of your screen is something that is known as a core score. And a core score is neural efficiency index. It combines the data from all three of the scans that I've talked about, the HRV, which is what we're talking about today, which is adaptive reserve. You'll see that that is listed under its title there. You'll notice that we measure, we're using SEMGs as postural energy, the amount of energy that is being wasted in managing gravity, and that we look and see if the patient's regulation at a spinal nerve level is now an end product. I'm going to introduce to you at the very end this principle of R for reserve, E for energy, and D for the depth of change. And you'll remember this when we're looking at interpretation on a global basis of looking at the RED, or the RED model of interpretation. It always keeps you centered, and it gives you the greatest opportunity to tell the story as it needs to be told. So the very first thing that we do is on the left-hand side in any interpretation is we check to make sure that the data is valid. And so it's very simple. We check and see that the patient's heart rate is within zone, meaning that the IHR, or that the red line graph, the instantaneous heart rate, or IHR graph, is in a reasonable zone, in this case in the 75 to 80 zone. And that you'll notice that other than when we started the test, the general flow within the GSR is well within normal. So we're satisfied that this data was collected. And I do want to mention this, is that before a scan can begin within the NeuroPulse model, the patient has to have a biometric test done to assure that they are within testable ranges. And we test that their temperature is under control so that they're not in a sympathetic dominant state through the temperature models. We check to make sure that their GSR is in a low state of arousal or in a resting state, and that their pulse rates and pulse patterns are not arrhythmic, and that they are collectible and measurable. We also have, I'm very proud of this, we also have algorithms built in that take out nauseous, or what we call ectopic beats. Not so many of them. If you have a patient that is not comfortable sitting there and moves their hand or loses contact, a flag will pop within the software that says, no, 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 not a good collection. So by the time you see this as a clinician, you are going to be more than satisfied that you are now going to be able to interpret what the HRV calculations are. So we take this data string on the left and we apply time and frequency domain analysis to it to calculate HRV. And what we do is we recognize that this person is in zone 1, not really far off the line in zone 1, but you can see that they are below the well-adjusted zone. Now, for somebody who may not have a symptom profile that puts them that close up, you get a chance to ask yourself and say, well, wait a minute, are there some masks that are on this reading that I should maybe be clinically relevant of? Because remember, this is just your initial scan. And the first mask that I always like to ask about, if it's a completely, this person could be in ripping pain, they could be, in a dysfunctional relationship, it could be that they're, under some type of who knows what, health crisis. And they plot up here, you might be saying to yourself, well, wait a minute, what's going on? And the first question I ask is, what medications are you on, or did you not tell me about? Because all medications, I don't care what they are, they impact the nervous system and bring it about, but especially cardiac meds. Is because if this person is on a beta blocker or if they're on statin drugs, those are designed specifically to drag that person out of a sympathetic dominant state, okay? And to lock them in there. Doesn't mean that they're well adjusted or that they're in there. It just means that they're having a mask or an artificial responsiveness that's going on with that. I suppose in some ways that's good, meaning that they're placed in an artificial state here. But our role as chiropractors is to understand how we can improve that without adding more drugs or without modulating that person's nervous system in other ways than an adjustment. So this is what we call our initial or our baseline scan. And you'll notice that the core score initial recognizes that in the top right. It talks about where we have exam number 1 and plots this person because of that plot in a transitional zone. We know they could improve. And I won't go into the scoring on this one, but it allows them to plot, and we do some very in-depth calculations to use this as a percentile. And so we then move to what is called scan 2, or the progress notice we refer to that as the first progress exam. And I want to place this on here is that in HRV world, but also in EMG and thermal world, the distinction that we're looking for between scan 1 and scan 2 isn't even the scoring, because many times it can go down because we're adding new quantitative stresses to make change. It's whether or not the patient is changeable. And you can see almost immediately that the person's HRV, I'm back to scan 1 here, has jumped into the green zone. And so this is ideal that they've changed. Their score went from a 75 to an 82. And we start to see that their overall progress is such that we're now seeing adaptive reserve being built. But it doesn't necessarily mean it's going to stay there. And so when we go into the scan 3, which is this ability to take a look at the comparatives, we start to see that there is a relationship into a stabilized response. This is actually scan 4. And what we're looking at is that they have been able to control it. But what catches your attention on the left-hand side, and I put this one in particularly, is that you'll notice that the collection had arousal in it. And it would be my recommendation as we start to take a look at this arousal model that this test be redone to assure that there is a state of coherence that's being built. But you'll notice that on the relationship that we have in continuation, that we start to see that there are comparative models that we can now build into our reports. So let's go back into the progress, because we can learn a lot on this. Pardon me, this is the comparative. I apologize, I jumped from that. Let me go through it again so it's there. This is initial, watch the green zone. This is the ability for us to go in a progress. We move in the same green zone in comparative, and finally in continuation, we stay there, but we want to make sure that that data is there. Let's dwell on this one for a moment in comparative. From scan 1, we get an initial or a baseline. To scan 2 in progress, we're looking for changeability. For scan 3, which is what we have right in front of us, we're now looking at a comparative relationship. Great. They're a little bit to the parasympathetic or what we would refer to as exhausted state, but not outside of the zone. So they're well adjusted. But we see that they are changeable, but we've established a trend now that the person is holding it there. And if we go in here and reestablish this as a good scan, we see that the trend is holding. And that's overly exciting. So what are we learning from this? Is that adjustments on a consistent basis not only unwind the tension that has a person outside of zone, but gives them the opportunity to move into zone, gives them a challenge to develop a trend. And what we know after the trend goes in is that we are constantly looking to see if we have established what it is that we need to make happen. So now we move into a child case study. And I've got a little bit of a treat here because I wanted to show you something of this. When we do children, and I put this in here because you'll notice that a child, in this case a newborn or an infant, is expected to have a very much higher heart rate. We also know that they also have a higher heart rate variability. And as a consequence of that, we know that in infants and children, there is a need to establish, because they have no voice, and we want to assure that their autonomic function is not only in balance, but that it's active. So we developed an ability to do pediatric scanning out of the same instrument, but having peripheral attachments of 2 forms. One for newborns and infants, we use an ear clip that I'm going to show you a video on in just a moment. And the other one is a finger sleeve. So let me introduce that to you right now. And this is a great friend of ours and a great client of ours. This is Dr. Dave Hansen out of Illinois. And he was kind enough, because he establishes himself in a very busy practice, but also a very family-based pediatric practice, to share with us some best practices, if you would, on understanding the use of the ear clip and the finger sleeve.
Hey everyone, Dr. Dave Hansen here, and I want to talk to you real quick about how to properly get a scan using the neural pulse unit, the ear clip, or the finger sleeve to measure someone's heart rate variability. Ideally, you'll be using the full neural pulse hand scan. And I say that because with all of the scans, you're going to be capturing a person's heart rate. But with this unit, you also have these two units out to the side, which are measuring both skin temperature and galvanic skin response. And the reason why that's important is if you're measuring my heart rate variability right now, and I think of something funny or something scary, that's going to cause a change in my heart rhythm. It's going to make it more variable. And that will give me an artificially good score because now you're capturing heart rate variability that is not a reflection of my physiology, but as a reflection of just what I'm thinking about. And so the nice thing about capturing the galvanic skin response and the temperature using the full units is you'll see that on the scan. That's what the blue spikes mean. If you have more than one big blue spike per minute, so 3 in a 3-minute scan, then you need to start questioning whether or not you're measuring that patient's actual heart rate variability, or if you're measuring their heart rate variability under just whatever arousals that they're thinking of. So ideally using that, but for some people, maybe they've got 2 little fingers, like if they're a little kid, maybe they're missing a finger. But there are reasons that you want to switch to either using the ear clip or the finger slip. Okay, so the first one I want to show you guys is the finger slip. This is what it looks like if you haven't seen one yourself yet. So a couple things to notice that are real simple. For one thing, you don't want to use this on grown-ups. It's too small of an opening there. It'll overly constrict the finger, which will include the blood vessels, and you won't be able to capture the heart rate variability, at least not accurately. So you want to use this on the little people, little kids, or maybe even like a super skinny grown-up, but really just thinking more like the little kids for this. But notice how the cord is on the one side. You want to make sure that that is on the top part of their finger. So you would want the finger to go in like this because the sensor is on the bottom. And so otherwise you don't be measuring their fingernail. You're not going to get a heart rate that way. So keep that, the wire on the back. You want to slide it all the way in. You want to make sure the finger goes all the way to the back. Some people try to put their finger all the way through. Obviously, that's not good. So you want to make sure they get good placement, which would look just like this, with their finger just touching the back of it, which puts the sensor right at the meaty part of the tip of their pinky. And that's the best way to get a capture using the finger slip. Now, one of my staff's favorite way of capturing HRV, especially on little people, is using the little ear clip. So this is cool because you can do this on anybody. We do this on newborns all the time. What you do is you clip it to the fleshy part of their earlobe. Sometimes you might have to move this around. You can keep an eye on the software to see if you're getting a nice steady heart rhythm or not. But move it around. Everyone's physiology is different. You might need to position a little differently to get a good strong pulse.
Well, that's the storyline. I could listen to Dave an awful lot in there. And one of the things that we know is that we can.
Hey everyone, Dr. Dave Hansen here.
We can start to really have a confidence level in building up a children's relationship with HRV. A couple of things that are really important. Children, especially ones that are more mobile, we were talking a lot about that, can be using on the finger clip, the finger sleeve. It allows us to really give our control mechanism. Sometimes you can have the child just sit there and make sure that they're keeping calm. But the other side of it is that because children have a much elevated heart rate, many times you can get away with a 2-minute collection and get enough string of data so that you can, obviously limit the amount of roll around time that kids have. And one of the things that is so critically important is that the autonomic balance especially is the same whether it's in adults or it's in infants. Activity should be higher in a child. We should see a greater amount of activity in a plot for a child, so that when we take a look at this particular one and we see that they are low, if you will, below the green zone, these are red flags for you to really start to recognize that we have the need to understand why this subluxated child, potentially subluxated child, has this obstructed nervous system that's not allowing the ability of the body to recharge itself. Balance is good, but we really want to understand if we can re-engage. And I think it's really important to understand that when you start to see, whether it's in adults or in children, when we start to see that there is this lowering of the activity, that probably the balance will be the easier of the two to get some change coming back to, but the recharging of the battery, the ability for us to bring back activity, is really a longer term project. So in the adult, I showed you that they were just slightly above the line, and you saw that they pop back into the green zone pretty quickly. When you start to see the plot being below that low threshold, that's not a very easy starting point. And I can't give you a direction specifically as to what care planning means directly on this, because each of us has a different model. But I can tell you this, is that in my experience, both at CLA and in practice, is that people train their patients to come in for care. And the reason is many times that they don't understand that it isn't just about unwinding the nervous system. We need to imprint new habits within the functioning nervous system. And it's that time and repetition that kick in the neuroplasticity. And so just like habits are formed, whether they be in a gym or whether we're breaking old or bad habits, we need to consistently do things in a very shortened time frame. The more we do, the faster we get better. And as a consequence of that, I like to set up what I call the rule of 12. The first 12 visits give us, and I like to do those rather quickly, could be within that 4 weeks or even shorter time frame, to try and see how engaged that nervous system is. I like to minimally help the patient understand that we have a 12-week intensive relationship, not based on only how they feel. That's interesting, but not mostly. It's how they function. And within a 12-week window of potentially seeing that patient 30 to 40 times, we want to clearly understand if they are changeable, but also if they're establishing, as we saw within that adult case study, a new trend that was going to keep them up or moving towards that green box. Remember, the green box in a chiropractic world is really a well-adjusted or state of coherence. Remember, the opposite of coherence, which is what we're seeing here within this child, is noise within a complex system. And what do we mean by noise? We mean that noise means that they are out of a state of ease or state, and they are possibly or are in a state of dyshyphenated ease. Bruce Lipton, who was talking about epigenetics, said it very clearly, is that you are either moving towards a state of coherence, or are you moving away from a state of coherence, but you couldn't be doing both simultaneously. So we need to establish trends that start to show that we are establishing a new state of coherence, especially in a newborn. And as Dr. Hansen was saying in that video, it's really important to have a confidence to get that pulse point. Remember, pulse points aren't limited. They are best on the fleshy part here, but you can move it around on the pinna. You can absolutely take it to the pinkies, even the toes, because wherever there is a pulse point, we can capture and make sure that we're gathering the data. Listen, the software is going to put a flag out if it wasn't good beat patterns. They're going to not allow you to capture. You either have to have enough beat patterns or you're going to have enough that aren't conflicted to get going on with that. So let's move on to this one. And you can see that no matter what we've done, even in scan 1 to scan 2, we haven't seen. I'm going to go back just to show you that once again. You'll notice that there was no movement on this child. If anything, there was a slight lowering. Okay. The heart rate was collected and it's high and it's in that normative range for an infant and child, but we haven't seen the move we are. Carry on. We need to keep moving forward. Okay, it's not establishing a trend yet. And this is concerning now. They've had 3 sets of data, but what is changing? And this is where you get to get really excited, because at this point, if the HRV isn't the indicator, let's see what is holding us back or what is changing. And we'll talk about that as being viewed through the EMG and the thermals as we start to go into the other deep dives. And finally, by the time we start to see this longer term project, we start to see that has now crested into the above line area, and we start to see that there is this improvement in the HRV, which means that we no longer are in this lockdown position, but that we have established that new state of coherence moving forward. And that is why it's so exciting to have the confidence, instead of how are you? Do you feel you? Do you like me anymore? Will you spend some more money? It has nothing to do with that. It's about saying you're in the right place. You're in the place that measures the power of you under a chiropractic model to be the best that you are. And honestly, using HRV in children is so powerful because it makes the invisible visible, but it gives a voice to that child's nervous system. So I want to just, as we come to this, I want to add this one more, continuation sign. And you can absolutely see that if we were down in that area, that by the time we just keep adjusting and get them into the well-adjusted zone, we have this confidence to know that they are going to stay there because we've established that new trend. So that kind of helps us understand a little bit about what care planning is in relation to looking at HRV. I hope you're starting to get a feel for the different zones that are in there, the different strengths that you have in terms of measuring and modeling your care. And I hope that you're really starting to see that you are so much more than somebody who makes people's spines or bodies feel better. You are so much more beyond the pathogenic model. You are the one in your community that sets the foundation for what will happen in that person's child's life. And it's so appealing. And here's where we go. Yes, you could talk about retention models improving under HRV. It's natural. Who would want to leave when they're having such amazing care that is being watched and progressively, modulated? But more importantly, we're seeing that if many people are brought in under a pediatric window, that then the parents begin because they want to see what's going on. But many times it's the reverse, as a parent might come in with a perceived chiropractic spinal problem, be assessed far more in a non-spinal way. And all of a sudden the conversation shifts towards, well, I wonder how my kids are. Well, I wonder how my neighbors are. I wonder if I can, give a referral to somebody else. You have the confidence now not only to build a relationship in your community with what people perceive chiropractic, but most importantly, using HRV as a non-spinal test, you establish yourself as the foundational element for people searching for wellness. And I can tell you that that's true. And let me share this with you as we sort of, wind our way down on this. Is that as I began this conversation, I mentioned that CLA has established itself as by far the most important and largest instrumentation through the neurofunctional model that has existed within chiropractic's history. And one of the things that we did was in 2015, we established the collection of each of the data sets from our clients so that we could store it and protect the data from them, but most importantly, that we could ensure that we could then scrape the data and work with data scientists and ensure that we would understand these trends, not only on a patient by patient basis, but on a global basis. And one of the most exciting things that I get to do is my role as owner, leader, chairman of this system, is that we get a chance to create a movement within the profession, perhaps a movement within healthcare. Because when this data gets published and when we show that chiropractic is that foundational element, there is no reason for people to become detractors of chiropractic. They should be attractors of us setting the stage for healing, for potentiating human performance, and for the ability for us to be an integral part with every human's life on this planet. And I know that's bold, but why not? Because I believe in chiropractic as you believe in chiropractic, that we didn't get into this to just make a living. We made in this to change lives. So one of the things that I love doing is as part of this movement is making it easier for everybody. And a few years ago, we said, well, how are we going to begin to create these neural profiles that aren't limited to just talking about one instrument or one division of the nervous system? What should we do? And so we created what was known as the neurotech. And I'm going to bring on our chief experience officer in just a moment to make sure that you are fully aware of how neurotech is how the neurotech is very much a part of the progression of practices. I just want to finish with this slide as a setting for where we're going to take the next two deep dives, and then I'll hand you off to Lisa Marie. But I think I've established that if we were to use the saying RED, that what we would stand was R is the amount of adaptive reserve that person has within their functioning autonomic nervous system. E stands for energy. And we know that if somebody is out of balance structurally, or that they've adopted a neurostorm posture, which I'm going to go into, that they are wasting energy at an incredible level. And we can measure that within their neurospinal functional motor system by using electromyography. And I'm going to do an entire deep dive on that, much like you have today. And finally, we want to see if people are getting sick from their experience and are dysregulating. So D for dysregulating, dysautonomia, and we're going to take a look at thermal. So